Hello, I'm Commander Christine DeForest, and I'd like to speak with you today regarding the role of task trainers in medical readiness. These are the views of my own, and I have no financial disclosures. Our learning objectives today will be to define the components of medical readiness, describe methods to achieve medical readiness, and in particular present procedural task trainers as a tool for supporting skill sustainment for our military clinicians. In defining medical readiness, it's important to recognize that there have been steps to establish a joint knowledge, skills, and abilities program. This has oversight by the Program Management Office, though we continue to have some variation in terminology and lists depending on the branch of service. This is knowledge, skills, and abilities for our Navy colleagues, individual critical task lists for Army colleagues, and comprehensive medical readiness program for our Air Force colleagues. Future state will capture this in a easier to use dashboard. This currently varies by branch of service and has not been consolidated. This slide, shared by the Joint Knowledge, Skills, and Abilities Program Management Office, depicts how skills will be supported through live clinical care with a need for additional modalities to meet the deployment-specific skills or platform requirements. And this is where simulation is of particular importance. Previously, there may have been a varying clinical case load that would support this need for our clinicians. That has changed over time. There was always a form of pre-deployment training that helped in filling some of the gaps and preparing people for operational environments. That continues to be implemented, and ideally would be a continued readiness posture where this training is spread out and more standardized, less of a just-in-time modality. In 2012, there was work to start defining skills decay. This was important and required collaboration between Army and Navy, producing 5 different projects that looked at identifying when and why there is skills decay, trying to capture a validated analysis tool for skills decay, and then determining what appropriate refresher training would look like with recognition of the varying courses available. This looked at 3 different domains: our surgical procedures, intensive care medicine, and outpatient invasive procedures. And from this, there was a look at 3 different integrated areas, which include our behavioral skills, looking at degree of confidence, how this may be captured by additional movement or pauses during a procedure, reflecting maybe recency of that procedure being performed or the clinician's confidence in the procedure that they are currently performing. And then additionally, this can reflect clinical exposure and recency of that. In this slide, we also show that there are a multitude of courses available, particularly for our surgical colleagues, in addressing training for open approach as well as team dynamics. These have varying amount of information delivered through didactics as well as hands-on practicums using different modalities, whether it be tissue or simulators. And important to see that the recommendation from this was that training is important at all stages of a surgeon's career, and this can similarly be applied to other specialties. This is where our simulation centers help in filling that gap, though this varies depending on site. There's different SMEs available, different amount of equipment. There's also variations in that equipment and differing access to tissue models or bioskills labs, which was some of the really highlighted opportunity that we saw in those previous courses. I emphasize that procedural task trainers help in filling this gap and they are scalable to be used at varying sites in helping in preparing our staff for what may be required in a deployed setting, as well as in meeting the agreed upon KSAs that have been published. Our Medical Simulation and Training Program Management Office helps in looking at standardization and centralization of equipment, and this is then with an acquisition lifecycle manager, which has been a positive change. We know that in simulation, there are different modalities depending on the learning objectives, and there is plenty of room for virtual reality and the advancements in that help us in looking at small team dynamics, communication, focusing on patient safety goals, things that are important and perhaps may not be met best through a task trainer. But task trainers help in looking at varying degrees of fidelity and reinforcing skills, both from the early learner through the advanced learner, in helping to offer opportunity for skill repetition or to refresh on a skill previously learned. There are many task trainers available. This can be very specific depending on the learner and the specialty. This helps in meeting the needs of our medics and corpsmen. It helps in meeting the needs for our nursing as well as our physicians. There is a role for task trainers, particularly in adult learning. It helps with varying stages of learning, from the initial fundamentals of a early curriculum to the application and reinforcement of our attendings, physicians, and more seasoned nurses. For military operational skills, this is extremely important, as many of our skills and KSAs may be required and appropriate in a deployed setting, but infrequently practiced or used in our stateside hospitals. This brings me to several examples where I would like to apply the value of procedural task trainers. First example here is the KSA of lateral canthotomy and cantholysis. This is agreed upon KSA across our service partners, and that has had some investment through our Army Medical Research and Development Command, in particularly the model that you see on this slide. This model has the option to change out the eyes to help in looking at tactile feedback, replicating increased pressure when an indication for lateral canthotomy with cantholysis. It also has tissue with the appropriate anatomic replication and the tactile feedback to help in reinforcing this skill, which is infrequently done in our controlled hospital environments here. We can see homegrown models, and what I show here is what has been easily accessible for some. If you have a 3D printer, it gives them increased fidelity in helping to look at the preparation for the anatomic component of it. Simply honing in on the rubber band with ping pong ball, this has been used as a homegrown static model for skills reinforcement as well. So you can see that this skill is met with across the spectrum of different training modalities. Our prolonged casualty care example will be compartment syndrome. And with this, specifically, compartment syndrome is an indication for fasciotomy. And when here in a controlled setting with plenty of resources, our orthopedic colleagues will be consulted to perform this. But in a deployed setting, our medics are expected to recognize, and our advanced medics to then move forward in a fasciotomy. They require reps and sets to have the confidence to perform this procedure, particularly with risk associated with it, and permanent disfiguring and effect on the limbs, physiology and functionality after, if perhaps it wasn't done properly, and even when done properly. There's also importance to have some feedback in the bleeding and appropriate anatomic compartments to reinforce the skill acquisition. Our Laerdal model options provide a modular component. You can see somewhat limited in the visual tissues as well as the tactile feedback of proceeding, but this can be incorporated into a high fidelity, larger scale training. Operative experience has a modular option as you see here, perhaps with some improved fidelity, but the interoperability and cost of investing in a different high fidelity model is prohibitive for many facilities. And there has been investment in what you see here as being a prototype, and our Army colleagues once again are providing an example where synthetic tissue impregnated with material to replicate bleeding can help in improving that confidence as well as feedback for an advanced medic acquiring this skill. You can see the task trainer being isolated for this skill, perhaps reduces cost and helps in augmenting training that may be performed in a field environment. So an excellent example here where this model can be adapted to improve realism without the cost or procurement requirements of a tissue model, but with good application and good technology to reinforce the skills. So wrap up, this is a joint ownership. Skill sustainment requires the investment of facilities, for clinicians to prioritize this as well in their cases and time allocation. There will be a need for live cases, but there is plenty of room for simulation to help in filling this gap, and particularly the unique demands for operational military medicine. Future investment will continue with virtual reality, which is outstanding for small teams, communication, replicating austere environments. But there is a role for procedural trainers, and this is important for looking at filling a need for our KSAs that have been published, as well as preparing for deployed environments. I provided a list of references and appreciate your time. Thank you.